Yamini's CV. Okay, Dr. Yamini Chokan is a senior embryologist at Institute of Reproductive Medicine, Chennai. She is widely known for her valuable contribution in the teaching and research in our field. She has been actively involved in advancing laboratory practices and sharing evidence-based approaches with our community. And today she'll be speaking on the topic current technologies for selecting sperm for ICSI, practicality and efficiency. So, Dr. Yamini, thank you for joining us, and over to you.
Thank you, ma'am. Good evening, and thank you so much for the kind introduction. So I'm going to share my slides. Okay, so today the topic that was given to me was much interesting, actually. It was about current technologies for selecting sperm for ICSI, practicality and efficiency, because all of us have been thoroughly read about what are the different sperm selection techniques available. But what is more relevant for usage in ICSI is something that I will be sharing in brief as much as what I know about. So in today's presentation, I would just be talking about what is the significance of a good sperm wash technique, what are the available techniques and technologies, their advantages, disadvantages, and their indications for use in each. So we do know that there is a global decline in fertility, and which is of a great public health challenge these days. And most of it, to amount to almost 50% of it, is contributed by male factors, which also includes the gonadal dysfunction, erectile disorders, and abnormal sperm quality by itself because of lifestyle parameters. So why is it important to select a spermatozoa? Because we all know that we have moved into a field where ICSI is predominantly used, and ICSI is more about the subjective selection of sperm, where we just see the morphology of it and select. So we still have it in our hands to decide upon selecting a good sperm, which will have good DNA integrity, because that is very important for us to have good fertilization rate, good embryonic development, and also reduce the risk of epigenetic abnormalities. So because we know that even in one semen sample ejaculated, there can be a very heterogeneous population of sperm, it is very important that we understand which step or which type of sperm selection or wash should be used for which kind of patient to be selected for ICSI. So to start off with, we all have been very used to using swim up and density gradient methods in our laboratories for ICSI sample preparation. So a swim up technique we know that it is based on the ability of the sperm to move, because a healthy motile sperm will swim up out of the washed pellet into the overlying culture media. By leveraging the spontaneous migration, this technique will almost select most of the motile sperm that is present in the sample. So which is the overall protocol of how it is being prepared involves the sample is allowed to liquefy, and after liquefaction, the sample is washed with washing media. By washing, I mean we will have to centrifuge the sample at least once or twice at different RPMs for 1300 to 1500, and the second wash at around 1200 RPM to make sure that we remove all the dead sperm and only the motile sperm is available in the supernatant which is received after washing. So after we overlay this pellet with a fresh supernatant, we'll have to incubate to around 20 to 30 minutes, after which the sample can be very well used for ICSI. And the fraction of sample that we see over here is motile ones, and which does not, remove the sample or the sperm which will have a poor morphology. So this is a probable drawback of why people moved on from using swim-up techniques into density gradient methods. So what is the density gradient methods principle? It is based on the difference in sedimentation properties of sperm with varying quality and motility in specific density gradient medias. So while using a density, we will have to make sure it is biocompatible with the sperm that is used. So these days, what we use is a colloidal silica or a silane-coated silica material. The centrifugation, we know it generates a force that allows a morphologically normal and a highly motile sperm to overcome the resistance which is provided by these two densities to settle at the bottom of the tube. So after the wash, the sperm's fraction of the sample that we see in the bottom of the tube is the one which is going to have the best of the quality. So what is the protocol of it? The protocol of it involves, as usual, we will have to make sure Is my slide projected? Has it stopped? I'm sorry.
We can see your slides.
You can see the
So
slide?
go ahead. Yes, yes. Go ahead.
I'm not able to see the slide. Just a minute.
Okay.
Okay, so is my slide visible?
Yeah, absolutely, Dr. Yamini.
Okay, I'm so sorry. The protocol of it involves where you will have to make sure that the sample is liquefied, as I had mentioned earlier. Following which, you will have to make sure that the sample is overlaid, as in the tube is overlaid with an upper gradient and a lower gradient. The upper gradient will be the one which has a lesser density. The lower gradient is the one which will have a higher density. And over these two densities, we will make sure that we overlay the sample and we centrifuge it at 2000 RPM for around 15 to 20 minutes, after which we carefully remove the supernatant. And in this, unlike the swim-up technique, the pellet is the one which will have the maximum of the motile and morphologically normal sperm. So when we take this sample, and we will have to wash it to make sure the remaining of the density is also removed, and this pellet is resuspended in a fresher media. So this is used for sample which has motility in it. So what do we do if the sample does not have motility? For example, if you are going to use a sample which is immotile and not non-viable, but immotile, or a surgically retrieved sperm which will not have much of motility in it. So for a lot of time and years, we've been using the hypoosmotic swelling test for this purpose, where the sperm is exposed to the hypoosmotic solution, and that sperm is taken and used for Icsi techniques. So what is this HOS solution? It is basically a hypoosmotic solution, which is the combination of fructose and sodium citrate. So why is it that we use these two components only? Because it provides a low enough pressure to challenge the membrane without causing any immediate or complete damage to the cell. So only the sperm which is alive will have the membrane intact, and only the sperm which has the membrane intact will respond to a HOS test. So hence we will be able to understand if the sperm is viable or not. So in this way, we will be able to select even an immotile sperm for its viability when we are doing an Icsi case or for a testicular sample. So briefly explaining the protocol of it, we will have to take the combined mixture of the hypoosmotic solution, introduce a small amount of your sample to it, leave it to incubate to maximum of 30 to 60 minutes, after which a drop of it is taken. If you're using it in an Icsi dish, place it on an Icsi dish, or if it's for analysis, place it on a slide and study the slide for the quality or the viability of the cells. So this is the general protocol of how we do a HOS test. But we have been moving from HOS test into HOS to other tests, and that the reason is it is very interesting, because there was one news which was published in 2024 which spoke about what was it before and what is it now. So we have seen that the presence of varicocele has a negative influence of HOS on the HOS test results, which means that if at all we are going to take a sample, expose it to HOS test, and this is from a patient who has varicocele, there is a probability that we will not end up with the harvest of the best of the viable sperm. And also they did conclude saying that the HOS test results were negatively correlated with epididymal markers such as neutral alpha glucosidase or selenium and carnitine levels. So this actually gives us a picture that you can use a HOS test only in a mature sperm, as in an ejaculated sperm, or a sperm from which you're taking a testicular sample from much closer to the epididymis. So they also saw that if at all the HOS test positive curling is going to be of the type B, it could be associated with chromosomally unbalanced spermatozoa, or the ones which do not have a full nuclear condensation. So even though a HOS test result can point towards selecting of a good sperm, there is a probability that certain sperms which are of good quality do not respond to it itself. So what did we move to? We moved to what is called as the laser-assisted immotile sperm selection, where we started using laser beams to touch the tail, the fag end of the tail of the sperm, to make sure there is a tail curling as a response to the laser beam. So this technique identifies viable sperm based on the biochemical properties of the sperm tail, where the changes in the membrane permeability and the cytoskeletal response is of major consideration. So this reaction is believed to be caused by laser-induced media influx into the sperm tail. Unlike the HOS test, where there is an influx of the hypoosmotic solution, this is more of a media influx, so it can be more friendlier to the technique by itself. So how is it usually done? So this is performed only by a diode laser system at the lowest working power, because we all know that the sperm is the smallest cell of the body. It is extremely fragile. So we have to make sure, even though we are giving a laser beam, it does not affect the quality of the head or the mitochondria. So we have to make it to be kept at the least working power, and a single laser shot is given at the lower 1/3 of the sperm tail. Once that shot is given, if it is going to be viable, the tail immediately curls or immediately moves, or it gives us a twitching. So this can be an indication that there is motility, or per se the viability of the sperm is available. So if at all you're going to have selection of sperm based on the microscopic sperm morphology, the first technique that comes to our mind is MSOME or IMSI, because we all know that the morphology is the most important thing when it comes to selection of sperm for Icsi. So we will have to make sure the morphology of the head, and these days the morphology of the mitochondrial piece as well, should be intact when you do the sperm for Icsi. So it is an innovative technique that combines both the Icsi and the MSOME, where by giving us a total magnification of more than 6,000. So by this, you will be able to even appreciate the smallest of the nucleus, sorry, the vacuoles. So there is something called as the MSOME score that gives us what should be the quality, or what should be the size of the nucleus, how should an acrosome look like, how should the neck or the tail or the mitochondria be. So based on that, we do mix these two, both the Icsi technique and the MSOME technique, to give us the IMSI, or the intracytoplasmic morphologically selected sperm injection technique, where the magnification by itself comes from magnification of various components in your microscope, which involves the objective lens, your magnification selector, video coupler, and the video magnification system by itself. So all of it together will give us a good magnification of about 6,000 to 8,000x. So what is the regular protocol of using an IMSI technique in a lab? We will have to make sure the sample is prepared either by density gradient or microfluidics based on the quality of the sample. After this, the sample is kept on a glass bottom dish or your Icsi dish, and it is examined under an inverted light microscope at using a digital imaging or your Nomarsky optics. So how is it seen under the microscope? When we see over here, for reference, I've just put up a picture where when we compare with a normal head, a head that looks small or large will be much appreciated in an IMSI technique than your Icsi technique. So with this, an embryologist can be very sure about the type of the sperm that he's selecting, and thereby doing Icsi. So if at all you're going to use sperm based on the functional properties, how do you select the good sperm? So this, we always have been doing a technique called as PICSI, or it is also called as a physiological Icsi. The physiological Icsi, as we know, it involves a selection of your sperm based on its ability to bind to the hyaluronic acid or the hyaluronin. So what is this hyaluronic acid? This is something that is found in the cumulus cell, which is the primary thing that the sperm encounters. On encountering these cells, what happens? The capacitation reaction is initiated, and after the capacitation reaction, there are certain receptors inside the sperm which are visible. And these sperms which are going to be visible, only then they can attach itself to the zona pellucida. So it is very important that a sperm should be able to attach to the zona pellucida, or pass through the cumulus cell to be able to reach to the oocytes or the oolemma. So by mimicking the natural fertilization process, PICSI ensures the sperm used for Icsi have intact DNA. By there itself, you will be able to avoid the risk of aneuploidy. So how do you do this? When we see under the microscope, there is going to be two kinds of sperm. The one which is going to have the head bound to the hyaluronin drop. Another one which is going to have the one which is unbound. So when we see a head which is bound to the hyaluronin, which is present on the PICSI dish, it is going to have a tail which is going to have movement which is similar to the sperm which has undergone capacitation. So with that, we will be able to understand that sperm which is bound has a good DNA, thereby good quality of your sperm, and thereby good Icsi results also. So how do you prepare the slide? You will have to make sure the dish by itself will have 3 micro dots, which should be added with 5 to 10 microliter of your media. After that, you will have to place your sample in it and have a PVP streak, which is used for manipulation. So the entire dish is kept overlaid with oil, and after incubation of this dish, which contains the hyaluronan drop, which is incubated along with the sperm will automatically bind to the drop, and thereby it will give us information about the quality of the functionality of the sperm by itself. The next technique that is based on the functional quality of the cell is the magnetic activated cell sorting, or the MATS device. So the phosphatidylserine is a negatively charged phospholipid which is located on the inner leaflet of a plasma membrane. In simpler terms, what I will say is, if for a viable sperm which is of good quality, it will have PS which is going to be present in the outer edge of the membrane, and they will be receptive to binding to what is called as your annexin B. So MATS is a technique that uses magnetic beads coated with this annexin to distinguish between apoptotic and non-apoptotic. So as we see in this diagram, what we see over here is the annexin B specific antibodies are attached with this phosphatidylserine, which is present in the sperm. And the ones which are not attached to it will come out without being manipulated. So the apoptotic cells will bind itself to the annexin, and it will be pulled to the either side of the tube, which is placed between the magnetic poles. And the ones which do not have any kind of apoptosis will not have any kind of expression of these proteins, and thereby will be getting as a harvest at the end of the tube. So as a protocol of it will require a sample preparation of density gradient or centrifugation, or any kind of sample preparation which will remove any leukocytes or other type of cells, because this technique will not be able to differentiate between a sperm or the other cells. So once that is done, the sample is incubated with annexin B conjugated magnetic microbeads. So an apoptotic sperm present in the sample will bind to the annexin B, and the ones which do not have any kind of damage will pass through the tube at the end. So by this, we will be able to identify the viable and the non-viable sperm which is present in the sample. So the next widely used technique that is being, predominantly switched to these days is your microfluidic sperm sorting technique. So this technique works on various principles, but all of the principle just has a basic one line which relies on the principle of passive motility-based swimming through microchannels or active manipulation via flow. So it just means that a healthy sperm will have the ability for it to be separated from the other cells or the debris or any kind of other cells or damaged cells present in the pool of the sample, to move to a place or move to a channel which will have just the good harvest of sperm. So what are the different principles, or what are the different ways in which a microfluidic device is classified? It is type 1, where it is motility based. The motility based ones, they isolate motile sperm from the semen by creating a barrier that only highly motile sperm can cross. For the second type, there is a physical property based, where these use microchannels or micropores or filters, in which the sperm's physical characteristics such as shape or size is tested, and only the sperm which has the best of the shape morphologically will pass through it, because the channels are placed at such a size. The third type is your observation system, where you make sure that these are allowed to move through certain systems like your Raman spectroscopy, where you will just have to observe the quality of it and then decide on choosing it or not. So what is put on the right-hand side are the different protocols or different ways in which the sperm has been separated using different devices. Because the devices are of varied nature, it is very important for us to be able to select each device for our requirement. Suppose we are going to use sample for Icsi, it is a different device if it is for a teratozoospermic or for a normozoospermic sperm. So this slide will talk about what are the indication of sample to be used for which technique, what are the advantages and disadvantages of it. So the techniques that we saw include the swim-up technique, which can be used for a normal semen, for a mild oligoasthenozoospermia condition. The advantages of it, we know it is simple, fast, and economical, of course. The recovery of highly motile sperm is available. It is a non-invasive, provided we do not push it through a lot of centrifugation. And also, it helps in reducing ROS production compared to your DGC centrifugation. So what are the disadvantages of it? If at all we are going to put a suboptimal sample, of course, the quality of your after the sample is being washed, the quality of your recovered sperm is going to be much lesser. For a DGC or your density gradient method, of course, it can be used for normal semen sample also and oligoastheno sample as well. It is simple to use. It combines both swim up and it improves the quality of recovery, because the quality of the sperm is also tested when it is passed through the different densities. But the only disadvantage, as I have already mentioned, is only the increased ROS production, the low sperm recovery rate, and also the, if at all we are going to use a highly viscous sample, there are challenges. So in a Hoss test is basically only used for non-motile viable sperm. It is simple and inexpensive. It evaluates the membrane integrity without damaging the sample. But what are the disadvantages? It does have few, where there is an increased difficulty in aspirating the sperm with characteristic tail bending. It requires a trained eye for it, because sometimes the tail can entirely curl around the head. So we can have a probability of mixing it up with a sperm cell and a not or any kind of other kind of cell seen in the sample. And it cannot select sperm with intact DNA. Of course, it is based on the motility. So the HA or your PICSI, the indications of it can be used for normal semen, for oligoasthenoteratospermic and round-headed sperms. The advantages of it, because there is going to be a hyaluronan receptor expressed on the mature sperm only, we are able to select a good mature sperm out of the lot, and also the ones which have intact DNA. But what are the disadvantages? It can be a bit of a complex procedure, because it takes a lot of training for us to be able to remove the sperm's head which is being attached to the hyaluronan. So with a lot of practice, we will be able to achieve it, but it does require a lot of procedural training as such. Next, for the MAX protocol, it can be used for normal oligoasthenoteratoma, for non-motile viable sperm, and for sample which have high DFI. So what are the advantages? It specifically helps us to select non-apoptotic sperm with intact DNA and normal morphology. But the only drawback of it is expensive, because Max has given us a lot of positive results, a lot of pregnancies and live birth rate. But because of the expensive nature of it, the usage of it throughout many centers are not predominantly seen. The next that we saw was the use of your laser-assisted sperm activation, where it can be used for non-motile viable sperm. What are the advantages? It helps in selecting a viable sperm, but which is immotile. It does not do much of damage to the sperm head. It is useful for selecting immotile sperm even in cryopreserved sample. But the disadvantage of it is the curling is much unclear, and sometimes what happens if we are to give a small beep, it just has a small twitching, which can be missed. So we cannot give more than 1 or 2 hits, which can damage the sperm by itself. So there is a lot of disadvantage about the practicality of it. So next comes the IMSI, which can be used for normal oligoasthenoteratospermic sample, and also for samples who are from male of higher age which have high multiple implantation failures. Advantages of it are based on the sperm ultrastructural selection, and therefore it is suitable for cases with repeated failures. But the disadvantages are more about the expensive nature of the technique by itself, and also that it's more time consuming. So what is going to be the effect of exposing the sperm to such longer conditions at room temperature or at 37 is still under study. It is non-standardized and it requires an experienced embryologist. So the last one, microfluidic sperm sorting, it can be used for normal sample, an oligoasthenoteratoma sample, and for a testicular sperm, provided we select the correct microfluid device. So it eliminates the damage caused by centrifugation, and therefore it will be able to maintain the DNA quality of the cell. And there is a factor of it being expensive and not a standardized technique, but it is being standardized these days, and a lot of papers and a lot of researchers have been coming giving positive results on their usage. So as I said, all depends upon what the type of the systems that we use for which technique. So I am going to conclude this brief presentation by saying the advancement in sperm selection have expanded the possibilities for optimizing outcomes in ART programs. While conventional methods remain widely used, emerging techniques assessing the functional and molecular aspect of sperm attributes offer valuable tool, particularly for patients with male factor infertility and previous ART failures. So it is very important that we select the right kind of technique, so that we will be able to not only increase the number of pregnancies, but also to increase the quality of live birth rate. With this, I'm just finishing my presentation. Thank you so much, organizers, for giving me this opportunity.
Can't hear.
Manisha can't hear. No, still.
Is it audible now?
Yes.
So thank you so much, Dr. Yamini, for that very practical and informative talk. And with this, we'll move to our next talk. And it is now my absolute pleasure to invite our respected president of Academy of Clinical Embryologists, Dr. Sujata Ramakrishnan, ma'am. She doesn't need any introduction, but for the occasion, Dr. Sujata is someone who always has guided, mentored, and inspired all of us. Her experience, leadership, and commitment to maintaining high laboratory standard have made a lasting impact on embryology practice across the country. At present, she is heading embryology at Nova IVF Fertility and Motherhood IVF. And today she'll be speaking on a very practical and critical step in Icsi, selecting the right sperm at the time of immobilization. So over to you, ma'am. We are honored to have you with us, and thank you for sparing your time.
Thank you very much, Dr. Manisha. Good evening, everybody. Before I move on with the topic, I should clarify that I'm no longer with Nova and Motherhood. So, it's okay. So, now again, thank you, Ace, for the opportunity. Let me share my slides. Can you see it? Manisha, can you see that?
No, ma'am, they are not visible.
Okay, 1 second.
Just a minute.
There is share rec. Yeah. Is it seen now?
Yes, absolutely visible. You have to do full screen, ma'am.
Okay, so the topic which is given to me is sperm selection during Icsi. And since Yamini had already spoken about a couple of the techniques which is used for selecting sperms at the time of Icsi, like PICSI and IMSI, I'm not going to be talking in detail about those techniques. Now, to set the context for this presentation, Icsi is a routine procedure in all our labs. And the success of Icsi depends upon two factors, not in any particular order. One, the procedure itself.
Ma'am,
Second,
your slides are not moving. Sorry to interrupt.
No, I have not moved it.
Okay.
I've not moved it.
Perfect. Sorry.
So, the second is the quality of gametes, quality of sperm and eggs. Now, as an embryologist, we do not have much of an role in improving the quality of gametes. But at least in the case of sperm, we can do something. We have the opportunity to choose the best sperm from the lot. So that is the context for this presentation. Icsi procedure itself has been standardized, but the selection of sperm, we have lot of opinions that it's a kind of a dogma in embryology. So in this presentation, I'm just going to attempt to discuss which sperm should we choose. How do we actually think, and what do we actually train our embryologists to do on the Icsi system, whether it is motility or morphology. In motility, what is the hierarchy? In morphology, what is the hierarchy? And how about the handling media? And these are the points which we will be discussing in the next 15 to 20 minutes or so. So let us start with the core question. What is your first priority? Is it motility or morphology? And the answer, it's my answer. And even, before I proceed further, I have to say, most of the information which is in this presentation is from my experience, from anecdotal experiences of other embryologists. Some I have actually validated with the evidence from literature. Others may not have, because, in IVF, it works like that. We cannot have evidence for everything. However, if you all have different opinion, then maybe we can discuss it during the panel discussion. So as the answer to my question earlier was, if I would choose motility or morphology first, my preference would be for a motile sperm. Why so? Because motility is the closest real-time indicator for the viability and the functional competence of sperm. And morphology is for deselecting sperm. For example, if I have two motile sperm and if I want to choose one and if I have to reject another one, I would use morphology as the criteria. And in all this, speed actually matters. The reason being, if you are exposing sperm to a lot of time at 37 degrees and to ambient environment, there is an increase in reactive oxygen species. There is also temperature and light induced stress, and this actually causes more damage to the sperm. So whatever decision we are taking, it has to be taken very quickly. There is a publication which actually says that when people observed sperm under IMSI system, like when the sperm is left on that IMSI stage for 2 hours, they saw the generation of new vacuoles. These are temperature induced vacuoles. So it is the point which we derive from that particular paper is, you cannot expose sperm, especially washed, prepared spermatozoa, to 37 degrees for a very long time. So hence, speed of decision matters. Now, what would be the selection hierarchy? First, go to a clean background. Then look for progressive motile sperm. And even in progressive motile sperm, look for smooth movement of the sperm. And then the last one would be a normal head. Now, to go a little bit deeper into these points, where to look, I said clean place in a droplet. It is always advisable to have a slightly elongated droplet. I do not know if you people can appreciate these images, which is in the center and it is on the right. Like this is from a monitor, and I don't know if you can see single sperm actually swimming along the edge of the droplet. It is here where you can actually identify individual sperm and then make a decision which one to use for Icsi. If you are going to the center of the droplet and if the sperm are actually very motile, in spite of having PVP, then you can get confused, because while you're looking at one sperm, another one would come and cross over, and that would increase confusion. So always go to the edge of the droplet. I do not know if people are doing circular droplets, but in my experience, I have felt that having an elongated droplet always helps. And you also have to go to a place where there is less debris, because you do not want reactive oxygen species coming from those debris and then affecting your sperm quality. Then about sperm motility, as I mentioned earlier, like you have to look for progressively motile sperm. See, you can see from this video, some sperm, in spite of meeting a hurdle, they just kind of cross over that. And
Sujata, you've got muted.
Yeah. Ma'am, we can't hear you.
Is still muted.
Are
you able to unmute yourself?
She's not muted. Oh, yeah.
can you people unmute?
Yeah, now you are.
Can you hear me now?
Yes.
Now you can.
Okay, I think I have to reshare. So from where did you stop hearing me?
Just the last bit. Just the last bit.
Last video, actually.
No. Okay. So you have to look for progressively motile sperm. And even in progressively motile sperm, the motility has to be smooth. What you're seeing here is a hyperactive sperm. Hyperactivity actually is important for natural fertilization. But we all know that in ICSI, this natural fertilization is bypassed, and hence it is irrelevant. And if you are trying to immobilize a hyperactive sperm, it can actually you can actually touch on the midpiece and then damage the mitochondria, and eventually you can have a poor embryo. Hence, when you're looking for a motile sperms, see to that the movement is smooth. Now, one thing we have to remember here is I'm talking about choice. Like when you have two different sperm, which one to choose? Suppose if a sample has, only hyperactive motility, then, you have to choose one of that. There is no other option. But if you have one where the movement is smoother, then go for it. Having said that, the next one, as I said, morphology would be my filter to deselected sperm. What would I do first? I would reject gross defects. I wouldn't even look at sperm which has, like gross abnormalities, what you are seeing at the bottom of this left side picture. But if there are minor variations, please do not sweat over it. It is okay. See, the picture what you are seeing on the right are all sperm which are labeled as normal by AI. But you can see here, Z1 is not a perfectly oval sperm, whereas Z5 is one. We will be thinking that this one is slightly tapered at the end, so maybe it is not good, but it's not that. When you see such minor variations in the size, you can actually go for it. Now, this is where, looking at sperm at a higher magnification helps. But before I even talk about this, I want to say, like not all of us have the facility of having a high power magnification in our laboratories. Not many of us have IMSI systems in our labs. So what actually I'm trying to say here is one should train your eyes, train your mind looking at sperm at a higher magnification. So what can you do when you do not have IMSI? Actually, when you prepare the sample for, with stains, like eosin nigrosin stain, and then you observe the sperm under 100x magnification under oil, that actually will give you an idea about all these parameters of high magnification. So when you, as Yamini had already mentioned, that if you're looking at a sperm under this 6,000 times magnification, you will see something like this: a normal sperm with no vacuole, and you see small sperm with smaller vacuoles, like very small vacuoles, and there is class 3 which has larger vacuoles, and then class 4 sperm which is totally abnormal. So what happens during ICSI is we are, see, definitely in under 400 times magnification, we will not be choosing these abnormal sperm. But I think, like we will be stuck choosing between this class 2 and class 3 sperms. Okay, at 400, we may not be able to appreciate smaller vacuoles, but definitely it will be very difficult at this smaller magnification to go for a very normal sperm without vacuole. However, if you constantly keep training your eyes every day, I suggest people who are aspiring to do ICSI or people who already are performing ICSI on a regular basis, if you kind of train your eyes for 10-15 minutes, looking at sperm at a very high magnification, whatever is available in your lab, definitely that will improve or it will help you to select the best sperm without these abnormalities. Now, what are the significance? Like she had already mentioned, if there are small vacuoles, they are very common, they are less significant because there are publications which say that vacuoles are a common, commonly occurring phenomena in the sperm. Sometimes it can also be triggered by the environment, as I had mentioned earlier, that if you expose sperm for a very long time at 37 degrees Celsius, new vacuoles are formed. But larger vacuoles definitely have an impact on the DNA damage and chromatin disorganization. Hence, it can affect the embryo development and possible, it also has an impact on implantation. So what matters here is vacuole, the size and the number matter, but large vacuoles can be observed at 40x magnification. And if you have a good contrast in your microscope, you will be able to see these larger vacuoles. So I always suggest that ICSI to be done at very high magnification. So this is also another assessment of sperm, which was actually developed by Kusato and Dr. Yona Barak, where the sperm is actually divided into different parts, and scores are assigned for each part. This is called HAV-BIC assessment. H for head, A for acrosome, V for vacuole, B for base of the sperm, and I for insertion, and C for cytoplasmic droplet. The scores are being given. Just for an example, if it is a normal head, a score of 2 is given. If it is abnormal, a score of 0 is given. So once we start looking at sperm at a higher magnification, then we also should know how to interpret it, because unless we have some objective parameters, interpretation becomes very difficult. So suppose if you add up all these scores and you have a sperm of between 8 to 10, then that's ideal for Icsi. If you have something from 5 to 7, that is acceptable, but anything less than 5 is you have to avoid. And you can see here when they say base, I'm sure head all of us know, and base is something, this is a normal base, this is how it should look. But look at this sperm, this has a cytoplasmic like droplet, and the base is also not right. And insertion is how the tail is inserted into the head. So all these parameters, and they say that head, vacuole, and base are the major parameters, whereas acrosome, insertion, and droplet are minor parameters. Now, again, I insist that this is not something which you are sitting and doing on an Icsi microscope. You have to train yourself to look at all these parameters and have an idea. So when you are going and sitting for injection, you will have a clear parameter or an idea in your mind that what is that I'm going to look for, so that I do not lose much time in selecting and deselecting a sperm. Now, another thing is the symmetry and the axis. See, suppose, mentally, if you kind of split the sperm head into two, both by vertical axis and the horizontal axis, they should be symmetrical. What you're seeing here is, appropriate. Whereas here you see in this side, it is kind of asymmetrical, whereas this side is okay. But these kind of sperm with mild asymmetry is acceptable. But if you have something like this, abnormal, the sperm is totally asymmetrical, then it is better to kind of avoid this particular sperm for Icsi. Now, we have seen that, like, what to choose, what actually should be given priority and all that. But it's not enough. Handling also is important. And PVP is an important component of our handling media, and also a part of the environment in which the sperm is there until it goes inside the oocyte. And all of us use different concentrations of PVP. And this particular study compares 5% PVP, 7% PVP, and 10% PVP. Why this study is interesting? Because it's a prospective study, not a retrospective one, and it is conducted on 194 couples, and they very clearly demonstrated that if you are using 5% PVP, then all your parameters like fertilization rate, cleavage rate, high quality embryo rate, and high quality blastocyst rate are all better compared to the other concentrations of PVP. But injecting using a 5% PVP actually could be difficult because sperm would be highly motile. But then as we progress in our injection, in our technique, we should actually, learn to use PVP, which is at a lower concentration. So what I normally would suggest to a person who starts is, like, you start with 10%. After you finish your injection for the day, you dilute that droplet, like add the equal amount of media to the droplet, dilute it to 7% or 5%, and then practice, like immobilizing sperm, have a timer, look for a good sperm, and then work on it, because it's just practice, and practice will make you perfect. Now, what are the practical tips during Icsi? One, minimize PVP exposure. PVP concentration, lower is better. Sperm selection, always at 40x. If you have that, some microscopes, I think Nikon microscopes, they have a knob where you can increase it by another 10 times. Use it, because it will always help. You will be able to appreciate finer details of morphology with higher magnification. And then immobilization has to be below the midpiece. See, for example, the tail starts here, and you divide this tail into 3 equal parts. So this would be your first 1/3, this is 2/3, and the last portion. The injection has to be done at the junction between this first and the second 2/3, so that you will have enough space, you will not be touching the mid piece. And I have also seen people immobilizing sperm very gently, just, like very, very gently. Some people, they do it very aggressively, that so that, like the whole tail gets broken. It should be somewhere in between. Actually, you have to use a little bit of mild aggression. And when I was taught ICSI, I was told that you should actually see that 90-degree kink. If your pipette is set properly, just one score across the tail will give you that 90-degree kink, and that will, it will kind of open up the membrane, and it will also help you to aspirate the sperm without any difficulty in your ICSI pipette. So immobilization has to be done just below the midpiece and has to be moderately aggressive. And once immobilization is done, sperm has to be injected immediately. And one great tip which I had received earlier was have less number of oocytes in your dish, so that you can use the time for sperm selection. Here again, another thing which I have to say, when I say like use less number of oocytes, don't use one single dish and keep on loading the oocytes there, because already the media would have lost its temperature and pH. So work with 2 dishes, one in the incubator and one on the ICSI system, and have to start with just 3 oocytes and slowly work up to 6 oocytes, not more than that. Even the best ICSI practitioners in the world, I have spoken to people from EV and other parts of the world, they do not take more than 6 oocytes at a time, because that will help you to conserve the temperature and pH. And remember, all these small technical details, they kind of cumulatively influence ICSI outcome. Now, actually, when you are sitting for ICSI, it is not, there is lack of knowledge. There is lack of, decision making. So what would actually be categorized as inefficient selection? Like if you constantly keep checking, rechecking, overthinking whether this sperm is good, that sperm is good, and slower decision, and that would be inefficient selection. Whereas, if you know to quickly reject a sperm, and if you work with clear criteria, and when there is a smooth workflow. And what I mean by smooth workflow is like you are just moving from one decision to another without much of hesitancy. Then, it's an efficient selection. And I have to tell you, this is the difference between experienced ICSI practitioners and less experienced ICSI practitioners. And if somebody, like if you see people quickly injecting eggs, please don't think that it is the skill, the way they are picking it up, they're just rushingly putting it inside. That is not the difference. Actually, the difference is they know how to identify a sperm very quickly, or rather how to reject a sperm very quickly. So all these parameters would actually make your selection of sperm very efficient. I would just want to give you a very small case scenario. Like we have a male with moderate motility and poor morphology. We have sperm with A, which is slow progressive but has a normal head. Sperm B, which is hyperactive and it has slight irregularity. Sperm C, which is twitching but with perfect morphology. Which sperm would you inject? My answer would be A, because progressively motility, and that shows the sperm is viable. It has smooth movement, and so it shows that it's stable, and the morphology is acceptable. Okay, but suppose if I don't have type A, I only have sperm B and sperm C, I would use sperm B, because in my opinion, I think function of the sperm is actually more important than appearance. If any one of you here in the audience, if you feel it the other way, please feel free to discuss this during the panel discussion. Now, when I say this, I'm sure, there are a lot of people who are thinking that, so doesn't morphology matter at all in ICSI? I'm not saying that. Traditionally, what we were taught to believe is morphology is equivalent to quality. And if it is abnormal, then we will have poor outcome. So hence, strict selection is needed. But what our experience and evidence in literature shows is fertilization is unaffected even if you inject abnormal sperm. there is a very weak correlation between morphology and the embryo quality. And on implantation also, consistency has not been reported. So there is something which we have to keep in mind. If we are injecting sperm from 100%, or like majority of the sperms are abnormal, then definitely that will have an impact on the outcome. However, if you are injecting from a sample which also has normal forms, then mild variations do not have an impact on the embryo quality. And some of the literature evidence I have quoted here: cleavage and embryo development, there is weak correlation. Fertilization, no significant impact, even if 100% abnormal sperms were injected. Blastocyst formation, not consistently affected. Like there is a lot of difference. When I make this statement, I make it very responsibly, that I'm not saying that if you use an abnormal sperm, you still get good blastocyst. That will also depend upon the quality of the oocytes and other parameters. However, you cannot say 100% of the times that I will get poor quality blastocyst if I inject moderately abnormal sperm. Then implantation also, there is no reliable prediction on that. And again, there is another question. Morphology is correlated to DNA fragmentation. That's what evidence says. So, how can you not give morphology its importance? Now, poor morphology is definitely associated with high DNA fragmentation, but again, the correlation is found to be weak. Morphology is a poor predictor of DNA integrity, meaning you cannot replace, DNA fragmentation tests with morphology, because, it is not a sensitive predictor. And Sandro Estes, in a paper in 2015, had mentioned that even sperm with normal morphology can still have high DNA damage, and vice versa, meaning abnormal sperm can also have good DNA integrity. Hence, since this is, like controversial, you cannot 100% rely on morphology for DNA fragmentation. Now, finally, to conclude, if I have to give an Icsi selection algorithm, I would say find a zone which is clean. Second, pick motile, progressively motile sperm with a smooth movement. Reject the defects rather than, looking for a perfect morphology. Reject abnormal ones. Make a quick decision and then inject. This actually would give you a, good outcome with Icsi. Thank you.
Thank you so much, ma'am, for sharing those valuable insights drawn from your vast clinical experience. You have reminded us that sometimes the most critical decisions in Icsi are made just in few seconds at the microscope by the virtue of your experience and your consistent practice. Thanks for reminding those valuable tips. And those small decisions can have a very meaningful impact on outcome. And with this, now we'll move to the most interactive part of today's session, the panel discussion, where we'll take up questions from the audience and discuss practical situations that we all encounter in daily in our laboratory work. And for this, it is my privilege to invite our esteemed treasurer of ACE, Dr. Rajvi Mehta, ma'am, to lead this panel discussion. Aarti, can I have ma'am's slide, please? Again, ma'am doesn't need any introduction. She's amongst the pioneers in country, holding very first doctorate in human IVF from ICMR and IRRH. And she is widely known as an outstanding teacher, a dedicated Iyengar yoga practitioner, and respected educator with extensive national and international teaching experiences. Ma'am, may I request you to kindly introduce our distinguished panelist and to take this discussion forward? Over to you, ma'am.
Thank you, Manisha.
Participants can also share their queries in chat box, even in YouTube and here, and these questions will be taken up during the panel. Over to you, ma'am.
So thank you, Manisha, for the introduction. Well, we have a full house here. We have over nearly 100 people here and many more watching on YouTube. That just shows how this question of selecting the sperm for Icsi is such a pressing need. So while the young embryologists are very keen on doing Icsi, there is a big pressure on their head in making the decision of the right sperm. And this just tells us how important the topic is. And therefore, we have left it quite an open house where we are, in addition to the previous two speakers, Dr. Yamini and Dr. Sujata. Firstly, I would like to thank them for two wonderful talks. Dr. Yamini gave us a quick overview of the different techniques of separating the sperms. And then we had Dr. Sujata giving us all her experience and all her practical tips, which made a big difference on how to use. She gave tips which I don't think any textbook can actually ever teach. So thank you, Dr. Sujata, for summarizing your very vast experience in those few slides. Now we are going to have other three very experienced people talking to us. We have Dr. Krishna Chaitanya. Again, he's a scientific head and clinical embryologist at OSS, who who would have a big responsibility because he has such a chain of clinics and he has to ensure that the quality is maintained. So we're going to learn from him on how he trains and helps not only himself selecting the right sperm, but all his embryologists in clinics spread across the country doing it. Then we have our next panelist, Dr. Gaurav Majumdar. And Dr. Gaurav is at the Gangaram IVF Lab Director at Sri Gangaram Hospital. Again, he has a lot of embryologists working with him, a very busy practice. So we're going to listen from him. And then we have Dr. Sonal. Again, she has also a very busy practice, 20 plus years of experience at the Ruby Hall Clinic in Pune. So now we are going to, I would like all my panelists to come on board. So I'm going to spotlight all of you. So we have all our panelists out here.
Yeah.
So along with, hello, we have Dr. Sonal, we have Dr. Gaurav, and I will have Dr. Sujata, Dr. Krishna. So this is actually going to be, we'll first take the questions. The question comes in, we have a person who is starting patients. We have very highly educated patients, Google educated, very rational, and with the 50% plus male infertility. So the question they're going to ask is that as it is, my fertility is compromised, the patient says, and there is a lot of, low quality sperms, low quantity sperms. And how are you going to select the best sperm? So I'm going to start from the patient's perspective of how do you counsel or talk to these patients when they come with such questions? And I'm sure Delhi, Pune, Hyderabad, you do come across this patient. So Gaurav, would you like to start?
Yeah, men are quite obsessed about their, semen quality. This thing keeps popping up of admitting new people. So I'm just,
Don't worry, I will take care of that.
yeah.
Ignore.
So yeah, men are quite obsessed with their semen analysis reports, and especially with the normal morphology percentage. If it's less than 4%, then it suddenly becomes a big deal for everyone. And so yeah, they are in general, they will always ask uh, about what can be done to improve their semen samples, and then one has to counsel them, explain to them that in IVF, even if your samples are suboptimal, then there is a very easy way of using Icsi to circumvent the problem, and we choose the best possible sperm and inject that inside the egg. So
Uh, Dr. Krishna, when they come, when you say we are going to select the best possible sperm, the question would be, how do you do that? Because do you come across a few smart
Yes.
patients, and how do you explain to them the best possible?
So, the first, for me, when somebody is talking, asking questions, that's a very, very welcoming sign because the person wants to get involved in the journey. And joining hands is going to make this journey easier. What scares me is when people don't talk because, we do all the process, things fail at the end. And if then they start questioning and we start talking, this is not going to work. So we all need to ensure that we need to welcome questions and open discussions. So that's point number one. Second, coming to the point, what Dr. Rajvi asked about, how do you convince them? I think, you need to spend some time taking them through the journey, telling them what you as an embryologist is doing here. We need to either use models or videos and help them understand what is happening in IVF. And more so if you're doing ICSI, you're picking that one sperm, and after they collect a semen sample to how it's processed, how the dishes are made, and how that one embryologist is going to spend time to pick one best sperm based on morphology and motility, and then put it into the egg. I think when you give them the overview, I'm sure most questions are answered, and then some people have more questions. The more read on Google, they get into the DNA, or they get specific into techniques like IMSI and all of that, and then that's a different story. But there's only small percentage of that. But if you
Okay.
kind of take them through the journey and you kind of help them with some visuals, I think most of them, that trust builds up. That they're in safe hands, and they've come to a place where the person is talking science. That goes a long way.
Dr. Sonal, would you want to add something?
Yeah, I mean, in my practice, I've seen around 10 to 15% of the men who were more interested in whether the volume given was enough. Starting with the volume. And so, it is important to understand how much the couple really knows. It is important, as Dr. Krishna sir said, that you spend time with the couple, make them understand that what is it that you are going to actually do and how you're going to tackle about it. So I think dialogue is very important. It is the beginning of the journey, and therefore it is important that the couple is made well aware of what the couple is going to undergo through the process.
So the reason I asked this question
Dr.
is that,
Adri, I'll
yeah,
just one more line
sure.
I'll add.
So
What I've
the reason I asked this question is that, we say the sample is poor. There is teratospermia, 3% morphology. So you have 97 sperms out of 100 which are abnormal. And, patients are bound to ask that how are you going to select one out of that one? The ratio is 3:97. How do you select it? And that's where the thing comes. So yeah, Gaurav, you can add
Yeah.
your.
So I was exactly going to talk about this.
Exactly.
That what's most reassuring to patients is that, and one must, give them this perspective that at the end of the day, we have to choose one sperm per egg. And so even if your normal forms are, say, 2%, we explain to them that your count is in millions. So now they get the perspective that, okay, out of every 100 sperms, one or two are normal, but that if when translated to millions, it means thousands or lakhs of sperms are normal. So that's very reassuring to them that, okay, I have millions of sperm and you need to select one normal sperm per egg. So, if they're like, oh, I have 8 eggs, so all you need is 8 good sperm. So that's why we reassure them. So they're like, okay, that's fine.
Okay. Fine. So now, since it's an open house, rather than we talking, I'm going to take up questions that have come from the audience. And audience, you are also welcome to, after I call out your name, you're welcome to unmute yourself and ask the question, or I can read it out. So one of the questions from Dr. Parth Bhatt is, what should be the strategy when DFI is greater than 30? And I would request the three of our panelists plus Dr. Sujata and Dr. Yamini, anybody can start. So when the DFI is greater than 30 and you're going to do an Icsi, what would be the strategy? Yeah, Sujata, yeah.
So, like when the DFI is very high, apart from whatever antioxidants the patient is on, what actually can be done in the laboratory is it is being proven beyond doubt that when you collect samples with less time in between, that shorter ejaculation time, then the DFI is significantly reduced. So we would ask for a second sample on the same day, like maybe just 1 hour after collecting the first sample, we can ask for a second sample. And this particular sample, if you put it through density gradient centrifugation, you will actually collect sperm which are, with good DNA integrity. And then if you do not want to put it through density gradient centrifugation, you can also use microfluidic device. But unfortunately, the devices what we have now are all just membrane-based device. They are not microfluidic device as such. So until we get a microfluidic device, we have to kind of use density gradient centrifugation. Here you have to work on the centrifugal speed. It has to be very low, not this 300 and 500. You can even do the first centrifugation at 150 to 200 G, and the next centrifugation slightly higher. So with this, to a great extent, you will be able to recover spermatozoa with good DNA integrity.
Okay, so now there's a question from Deepam. Your question is also answered. Now there's a question from Vijay about you when all the sperms are immotile and you have done an HOS test to identify the live sperms, but then the sperms also have a cytoplasmic droplet defect in the mid piece. Then how do you use it for ICSI? And how do you know whether it's a positive or a negative test?
I didn't understand.
So what he's saying is that it's immotile sperm sample, you've done an HOS,
Okay.
and then you are unable to identify because this sperms also have a cytoplasmic droplet defect.
No, you will be able to
So
identify because the entire
we want
tail will
some tips
loop
on that.
around itself.
So I think, Gaurav, the question is, you do a horse, you know it's a viable sperm, but these viable sperms have a alarmingly big cytoplasmic droplet. So the
Okay.
question probably I'm assuming is, now do I inject it? So, in a situation like this, devil versus the deep sea, for me, what's important when I'm doing ICSI is a viable alive sperm. And you've got 10 sperms. Now you'll have to pick and choose relatively which looks morphologically relatively normal. You can never get an ideal morphologically normal sperm. You don't want something with a tiny pinhead, two or three sperm tails, that kind of gross abnormalities, or a macro head which is not getting into your pipette. But a cytoplasmic droplet around the midpiece is saying that the spermiogenesis is not completed. But again, with so much of testicular sperm ICSI data that's published, where we are saying that the KPI seems to be reasonably accepted and maintained. If you've done your horse, if there's coiling, immediately come back, wash it or rinse it in buffer or PVP, score it, inject it. I'm sure you're going to have a fertilization.
If there is a small cytoplasmic droplet, then it's still acceptable.
Yeah.
You can use that sperm. If you don't have any other without ones, obviously first you look for sperms without any. But if in case you cannot, then you can go for that.
So basically, when you want to select such a sperm, when you have identified a viable sperm using the Horse test, what you can do is that among the lot that is available to you, you can give more importance to the sperm who has a better head morphology,
Yeah.
followed by the middle piece morphology. I mean, that's all you can do in this
Yeah,
case.
yeah,
Yeah,
Sujata.
Dr. Sujata, go ahead.
Assuming that, like the question is, if the tail is coiled so much and then you also have a droplet, and if you are not able to differentiate, one good way to do a Horse test is take your sperm in the ICSI pipette, go to the Horse droplet, do not release the sperm completely into the droplet. Keep the sperm head midpiece in the pipette itself, just release the tail, and if it coils, it's easy for you to identify. So you will not have a confusion between the droplet and the coiling of tail, assuming the question is this.
That's what it appeared. Of course, the person who's asking question is also welcome to unmute and ask. We'll go ahead with the next question. Sujata, you are very clear that 3 oocytes, maximum 6 oocytes per dish. Prepare 2 dishes. Now the question is, during ICSI, how many sperms can be in the injection pipette? Single
One at
sperm
a
or
time.
many sperms at
One
the
at
same
a time.
time? Would you like to? Because there is a lot of confusion where people think that they are more skilled if they have more sperms and they can go injecting 3, 6, 8, one after the other. So would you want to elaborate why they should not get into this kind of a situation? Because common sense tells that please don't do it. but it's something which they have picked up somewhere. So I would like these esteemed panelists to,
See,
now, do any of you go for more than one sperm, two sperms, three sperms?
Yeah, I do.
Okay. So yeah, please give both your point of views.
so I would actually, not advise that because, see, unfortunately in our country, ICSI is more like a race. Whoever does the fastest ICSI is they're considered to be highly skillful. But when you speak to people who are working, say, for example, I spoke to an embryologist who's working in a lab where 100% of the activity, happens in a closed chamber. There, the whole denudation, follicular fluid aspiration, everything happens inside a closed chamber. And even their ICSI system is within the closed chamber. In spite of that, they do not take more than 3 oocytes or 6 oocytes at a time because they feel that whatever time they get, it helps them to kind of use it for the selection of sperm. Now, once you select the sperm, many a times you can see you will not have a good control if you have 2 3 sperms in your pipette. I know Dr. Gaurav, like he is blessed, but then sometimes what happens is your system actually can play up. So what happens is the first sperm will go smoothly, the second sperm also might go, but when you are coming to the third sperm, there is a gush, and then you will have lot of PVP going in. So what happens is it becomes very difficult for injecting the oocyte in a controlled fashion. So, and here, like gone are those days when ICSIs are performed by extremely experienced embryologists. These days, in our system, we have to have people who have just, like 1 to 2 years of experience in ICSI doing the procedure. So, it will always help to have some kind of a standardized protocol so that, they don't see something like this 6 7 sperms in a pipette, and then they attempt to do that, and you see a lot of multiple fertilized oocytes and things like that. So I think it is better to take one sperm at a time.
Can I add
So
something?
That's what I
yeah,
advise people. Yeah.
Yeah,
So,
can I
so
add
you are
something?
suggesting that you are bringing out the eggs and the sperm together, right? So all the time that you are actually selecting the sperm, the eggs are also sitting outside.
Yes.
Okay, so see, that's where the difference comes in. So there's another way that ICSI is practiced now, in a huge number of labs in the world, where they first dedicate time towards sperm selection, right? So if I know that I have 6 or 8 eggs in a dish which need to be injected, then I will make a PVP dish, a separate one, and I will choose sperm. Sometimes there are some difficult cases where it takes a little bit of time, right, to pick up sperm. So we do the selection and we have multiple drops of PVP in that dish. Some are with the sperm sample, some are empty, where we immobilize them and then we line them up. I wish I had pictures, to show. So we line them up, and what happens is we are also able to evaluate the sperm relative to each other. That's when we know that, a sperm head is maybe relatively larger or smaller than the majority population of sperm in that sample. So this gives us time, especially in cryptozoospermic samples or testicular samples or severe oat samples, where sometimes it can even be hard to find a single sperm. So we do that, we make a pool of few sperms, and then maybe I am blessed, but maybe
No, I
not.
think this
Maybe
is
a
the
lot
right
of people,
strategy, Gaurav.
maybe a
No,
lot
No,
of
for
people have that
so,
proficiency. So we
so
pick up a few sperms, we adequately space them. We've had now experience of more than 20 years of doing this.
love. But
okay.
considering that there's a large audience here, and I'm sure there are a lot of people, beginners and mid-level
Yeah,
as well.
correct.
There is
Yeah, so
the
I
message that we all want to convey to a lot of people here out is, you know, do not take multiple sperms at once. It's not about how confident I am. What shouldn't happen is sometimes, as Madam said, the PVP gushes, or I have seen certain times my embryologists, when I tell them, one at a time, but they still are over enthusiastic to take 4 sperms. The first sperm egg they inject, it's fine, but when they're doing the second or third, 2 sperms overlap and sometimes they come closer. And now that's happened when they are near the cytoplasm, and they have no clue what to do, and they might either end up putting both sperms or one in the PVP, one in the cytoplasm. Sometimes it degenerates the eggs. I'm like, what is the rush? Please understand that saving that another 4, 5, 10 minutes, what are you going to do with those 10 minutes? Watch another
No,
Instagram?
that is true, Krishna. But what I am saying is
No, Gaurav, I
that
think we
that
shouldn't be
Okay,
no,
letting
no.
this
okay,
message
What I am
across to
saying
the
is that this
people
is
that
another
multiple
way
sperms
of
is not a great
doing.
idea.
This is
No,
okay.
no.
another way of
Can
doing
I
things
just,
where you are majorly reducing the exposure time to eggs.
No, no,
Gaurav,
I
okay, wait.
understand
Gaurav,
that
Can
whole
I
thing of
intervene?
can I say something here? Just an answer to Gaurav's this thing. See, Gaurav, like we have been doing ICSI for how many years now? More than 20 plus years, right? Like so, we know. Suppose if you immobilize a sperm and you put it in PVP, how long it can be there. But if we say the same thing to somebody who's starting new, and if they are starting, say, for example, with 20 oocytes, and if they start immobilizing the sperm, and there also there is a key that when you are putting the sperm, you only have to very gently kind of make it stop moving. The actual immobilization process, the membrane rupture, happens just before ICSI. So all these things becomes very difficult for them to process, and what will happen is the sperm will be lying in PVP for a very long time, and then even a good sperm will become bad because it is there for a long time. So I think
I can see people
One
getting
minute, one
very
minute.
sensitive about this.
No, 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 Gaurav.
So
I would
I
just
will.
like to intervene. Now, purposely, we selected Dr. Krishna and Dr. Gaurav here. You have Dr. Krishna, who has a large group of clinics and people under him. You have Dr. Gaurav having a large group of people under him under the same roof. That's the
Yeah,
big
yeah,
difference. So
yeah.
you know exactly
And
what your
we
people are
spend a
doing.
lot of time in training.
So,
We spend a
I
lot
understand
of
that.
time in proficiency.
Yeah, Gaurav. So the question is, these are not two different viewpoints. There are totally two different conditions. So the
Yeah,
message is that you have a very senior person. Don't imitate that senior person, because if you imitate, remember, imitation doesn't give you the experience that that person has over decades. So Dr. Sujata started saying that, you observe the sperms, 100x, keep observing, keep observing. Even while you're not doing ICSI, it gives you some learning. So here, this is why we put this. So when Dr. Krishna says, yes, it's not about his skills, please remember that when you're asking this question, you are still at a stage where you are trying to uh, imitate somebody. So when you have the skill, you know how to do it. You also have the
yes,
confidence. So that is
and it's
something.
important to know that what is the extent of the skill which one must develop. We
Yeah.
are.
So the don't try to imitate him, but try to understand that what can happen. So it is very, very clear that, if he is talking when you have experience of 20 plus years, then possibly you will be on a webinar and you can share your experiences. To start with, I think one should go with what Dr. Krishna and Dr. Sujata said, because they are also having a large group but scattered, trained under various parts. Yeah, Dr. Sonal, you can
Yeah,
put in your.
so there are two things I wanted to say. First thing, I believe that precision is more important than the timing, the duration of ICSI. So initially, when the person starts learning, we all have went through it. It's the precision that one must master. And second important thing, especially Dr. Gaurav, we had faced a condition wherein the patient was cryptozoospermic, and with lot of efforts 8 to 10 sperms were collected and they were about to be shifted in another droplet. However, during that time, the suction went bizarre and all those sperms were lost.
No,
So
no, no,
now
no.
we
Don't
have
give
to,
this message. Don't give this message.
yeah,
You're talking to someone who's doing 2000 cases a year.
No,
This is
Gaurav,
established protocol. This is established. I don't want this wrong message to be given that
no,
to
Gaurav, the
shift
message
dishes,
is
you will lose sperm.
the
No,
message
that
is,
doesn't
this for
happen.
the
no, 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 no.
newcomers.
That doesn't happen because no, there are multiple ways to do a thing. Please understand that, right? If you are used to doing a thing for the past 20 years in one way, it doesn't mean that there aren't other ways to do the same thing, right?
Agreed.
So we
Agreed.
should then agree to disagree here,
No,
but
Gaurav, the
we should
question
not.
is not questioning you. The
No, no,
question is,
I am not talking about myself. I have seen thousands of people, big laboratories in the world doing Icsi like this, where they don't want the exposure time to go up.
yes,
So,
but
so this is
after they
not
have
me,
this
me
skill, no, it's
against
not about you.
anyone else.
No, the question is the message we are trying to get across is you need to get the skill, then the speed.
Yes,
That's
yes,
very clear.
of course, you have to develop it.
Because,
But,
yeah,
but
so that's the message.
this message that you can spend time first on sperm selection without exposing eggs is very important. You
Of
know,
course,
Yeah,
I
agreed.
think I think
Agreed.
this
Yeah, yeah.
people
Can I
have to
ask a question here?
understand that you have to spend time on sperm selection,
with that,
but
yeah,
your
go ahead.
eggs cannot be sitting outside while you're doing that. Please,
Yeah,
please
Parsu,
remember
please
this.
join in.
No, see, there's another thought process. Like, see, for example, is there some kind of a timing from your immobilization to ICSI? So when we are looking at taking these kind of situations, I think there was always this thing of now, when do you immobilize? Within what time you should use that sperm to inject? So those kind of things, how will we
You have
address?
to
So is
minimize that time. You
how
minimize
do
it.
we? Hmm.
You
Okay.
minimize it. You don't
So,
want your sperm to be sitting forever. But this is a concept that one must think of, that when you are selecting sperm, your eggs are unnecessarily getting exposed. Your temperature might be wrong. You might be losing pH, or anything can happen. There's ambient
Gaurav,
VOCs.
just a small correction here. See, we are talking about scenarios where, as I had mentioned earlier, where we need to choose. See, if you're talking about cryptozoospermic, or if you're talking about, like testicular biopsy sample, there is nothing to choose from there. In the sense, you have to pick up sperm. Definitely, 100% of the times, egg is not there outside when you are selecting sperm. Here, we are talking about, say, for example, an oligoasthenoteratozoospermic sample, where you find lot of progressively motile sperm, and in that case you can take your sperm and egg together, but restrict the number of eggs to 3 to start with. Maximum, when you are skillful,
Yeah,
you can
that is
go up
for
to 6.
beginners.
And
yeah, so
even
this
for
is response.
experienced people, even I
That is
would
for
like to
beginners.
like take
For
one
beginners,
sperm
you
at
will
a
do
time.
maybe 1 or 2 eggs.
No, and then one sperm at a time in my pipette, because I wouldn't want multiple sperms in my pipette, because that is whatever the sperm is. However, like, you have the egg, you have the sperm, you do the sperm selection earlier, or you do it along the simultaneously. But whatever it is, my message would be, do not take more than one sperm. At the most, if you want me to kind of be a very less strict examiner, I might say take 2 sperms, but not 5 6 sperms in your pipette. That is not at all
Okay, I think
advisable.
we'll end it here. The question is again, I would say it's being asked by people who are relatively new, not the highly experienced ones. So those experienced people will not need you to validate what they do. That will be in a different forum, in a very scientific kind of thing. So I think the message is go slow, develop your skills, develop your selection ability, then you can go for speed. Now there are other questions that have come in, and the thing is, Jatin Sharma asked, does the sperm morphology affect the embryo development in Icsi? Yes. If then, how do 0% poor morphology, 0% normal samples give positive results? So when you have total teratozospermia, how do you get normal results?
Depends
So I
on what
think
type of teratozoospermia you're dealing with.
exactly. Yeah. Also, You
There are
know,
certain conditions like
correct.
globozoospermia, which have very poor outcomes, which have
Yeah,
very poor fertilization rates despite using activation.
yes,
And there are certain deviations which are very, very slight and
yeah.
from the normal. And w- the outcomes or the impact on the outcome, it has a direct association with the severity of the deformity in the
I think it's
sperm
very,
head or
yeah.
the neck or wherever.
Yeah, so I think it's very clear. Don't, it's teratozoospermia is a very broad term. So you need to be clear what it is. So don't think that if you theoretically say that the sperm morphology affects and there's total teratozoospermia, you'll not get results. So now the next question that comes in is somebody wants a really practical hint on how to select sperms on PICSI. So maybe if Yamini is around or any of you can talk
No,
about,
Gaurav is the expert when it comes to PICSI.
huh?
Gaurav is the expert. He's
Yes, Gaurav,
because they
please.
No,
regularly in their practice use PICSI.
we've done a lot of PICSI. We do PICSI.
Yeah, so just tell
Then,
them some
then nowadays
practical.
we like to do the Zymot uh,
Okay.
microfluidic. Dr. Sujata, you said that Zymot a microfluidic device?
No, it is not.
Membrane
Just
It is
is.
a,
a
it's a
membrane, right?
membrane.
But it selects on the basis of motility, right?
No,
It has a
actually,
membrane filtration also.
they
I,
have
I
double.
wanted to ask you this during your presentation. So because what I'm given to understand is
We
that
had a
Zymot, uh,
Qualis sperm sorter, you remember?
Yeah.
Qualis one, that is a microfluidic device. There is no membrane involved there. Straight away,
okay.
the sperm moves through channels. But all these Zymot and this lens hook, all of them are membrane-based
Membranes.
But
devices.
but they are
is it a
so
combination of both membrane and
Yeah.
There
See
are
fluid?
what?
no
yeah.
Actually,
channels there.
it's not that it is a hardcore multiple channels, but it is basically two channels or something followed by a filter.
Yes, so but
I believe that.
microfluidics, like it is supposed to be through smaller channels and it selects only based on that.
So,
But
Sujata, what does zymote like when you inject it until it goes to the larger chamber? There are those microfluidic channels.
no,
Major one comes from the migration with the filter.
Is there a microfluidic channel in Zymot?
That's how that's what they started with when they started it earlier because they talked about the
But
nanometer
they are
height level.
claiming that
Is primary first.
Zymot separation leads to reduction of DNA
DNA
fragmentation to
fragmentation.
0%.
but that
Reduction.
we observed that with Qualis also, Gaurav. Like,
Yeah.
like
Okay.
we had compared the sample before and after processing it through density gradient also, we found that from 30% it went down to 3%, 2%. But with microfluidics, we got 0%. Microfluidic device is that Qualis sperm sorter device.
Okay, now Gaurav, since you
Hmm.
have been using, do you use both? Like use microfluidics or zymote, whatever we want to call it, migration techniques that you have it, followed by PICSI. Do you prefer
See,
doing any
we
one?
no
Because the
we
principles of both are different.
we've just had very little experience of using the Zymot
Zymote.
or devices like that. We've been using PICSI for a long time now.
So
And
coming back to the previous the
yeah,
question from the audience, maybe you
yeah,
can guide them on how to select, and then
yes,
we'll go ahead with the
yes.
Zymote.
So PICSI works very well for samples which have good motility.
So
If there are asthenozoospermic samples, then it's very hard to do PICSI.
So how to do it? Like the question is like, once they are binding it, they want some tips on how do you really aspirate the bound sperms
No,
or pick up.
you just have to, it's not hard. You just have to take the pipette to the place where the sperm is bound. And what's a little tricky is that the sperm is rotating, continuously. It is bound at its head. And since it's a motile sperm, it starts spinning like a top. So you just have to position the head of the injection pipette in a way that when you apply suction on the head, it detaches and it comes in your pipette. So It's not hard. It just requires, exact focal, positioning. And the sperm will detach from the matrix and enter your pipette. And then you can take it to the other drop where PVP is there, release the sperm in that drop and immobilize it.
Okay. So the reason I asked both, because Zymote is supposed to decrease the DNA fragmentation, and therefore there was also this Palermo's paper where you have, more PGT.
Zymote is easy because Zymote you will get a yield, right? So you
Yeah.
put neat semen. What I like about this other system is that you don't have to centrifuge at all. You just put in neat sample, and after 20 minutes, you get these motile sperms which are separated, and allegedly they have no DNA fragmentation. And then you can do a normal ICSI. Just
Yeah.
pick that
No,
sperm up and do a normal ICSI with them.
practically, yes. The question is that Zymote, we are getting sperms with no DNA fragmentation or less DNA fragmentation, while PICSI is trying to simulate cumulus binding by binding to hyaluronic acid.
Zona binding. Zona
No,
binding.
cumulus.
No,
Basic
it's
HA
cumulus. It's
binding.
cumulus.
It's
It's
cumulus.
not
It's
zona.
hyaluronic acid. So PICSI is hyaluronic acid binding.
Mhm.
So basically, we are having one after the other. So any of you recommend or do both, or do you think there is rationale in doing
No
both?
rationale. No.
No.
I wish our patients had so much of money.
Exactly.
Honestly, I'm again, let's not get anecdotal. Right now, the literature, if you look at meta-analysis and RCTs,
None.
PICSI, even used in specific subgroup population, does not seems to, help us enhance live birth rates. So I think, but
No,
you
but
just
in
have
the
to
in the
pick and
list of
choose where.
HG add-ons, Peaks is the only add-on
But
which is
but
Gaurav,
again,
Gaurav,
recommended. And you know what, PXC, how we don't use PXC for everyone. We use it in only very specific cases.
and what are
Uh,
those specific cases?
Yeah.
Specific cases are patients where either there is very high DFI, or they have a history of RIF, or they have a history of RPL where nothing
But
seems
how do
to
we
be
know
working.
it's your PICSI which has actually finally made a difference? I think it's difficult.
I am
It's not that
see.
I'm wanting to.
I am
Uh,
referring to data which has been published where they have shown certain benefits
no, we
of
need
doing
to look
PXC.
at randomized control trials, Gaurav.
None of
I
these.
don't really think our
No, see,
individual little small
let's
cohort
not talk about
experiences.
RCT in that way. None of the add-ons have been proven
Exactly, that's the
beyond.
whole point.
Yeah,
None of the
but
RCTs.
there are certain
I
things you
want to
need
make
to
a
do
point here.
sometime.
Gaurav, you made a very
So,
valid point that you use PICSI only in cases where the motility is okay, right?
yeah,
But
yeah.
unfortunately, what I have seen in many places is the moment you have extremely poor motility or extremely poor morphology, they write PICSI.
No, no,
And
you can't do.
yeah, no. And then what happens is the people lab is forced to do PICSI, and the outcome it very clearly shows that compared to regular ICSI, PICSI outcomes are much. The pregnancy rates are
Yeah,
poorer,
yeah.
and so this is because
So no, no, it has to be used in patients
yes,
who have good motility. And
I
I'll
think
tell you the practical
emphasize in
aspect.
that one, yes.
Let's
Yes.
not debate about whether it increases live birth rates or not. There are many procedures which don't, but we still do them, including PGTA. But let's not go there. I am saying that as a PICSI practitioner, something which helps is sometimes very good samples with very good motility. You will see a stark difference on the uh, PICSI matrix where you see very poor HA binding and only very few sperm, and they are all good motile sperm which are running across the PXC dish, but only 20 or 30% of sperms are binding to the HA matrix and the rest aren't. So there I feel, and this is a very small subset. This is a very small subset of patients where you find actually good counts, good motility, but very poor HA binding. And here, so this is giving you a real-time idea of DNA fragmentation index. Whereas in all other methods, you have to blindly believe
No,
that
no, no.
sperm is okay.
Interestingly, what I would like to say here, that here is PICSI is we are trying to imitate the sperm's binding to the cumulus or hyaluronic acid. Again, we are making a assumption that, and which may be true, that in nature only the non-fragmented or intact DNA sperms bind to the cumulus.
It is
Of
not
course,
an assumption. It has been
yes.
proven now with
Okay, so
experiments. It
that's
has been
where, so we
proven.
are sort of, that is a selection criteria. And
Yes.
subsequent to that, that is the premise. So then in cases where we do not have that condition, that's where it is not going to be useful. So it is just going to be an add-on where it is not showing benefit.
So,
But
so
possibly,
there has been a RCT, a multicentric trial, a very, very large RCT in the US, where they showed that overall PICSI does not improve live birth rates, but in the subset of patients where HA binding is less than 65%, it leads to a significantly reduced miscarriage rate in patients who exhibit this.
makes sense because you're
Yeah.
selecting the better sperm.
So it is the key is that it doesn't work across patients, but in selected subgroups.
Okay.
No, and another thing is, like, I had an opportunity to speak to someone from New York who've been, the pioneers in this PICSI, not now, some before COVID, 7-8 years back. And what they said was, if you have to do PICSI, first do a hyaluronan binding
Makes
assay.
sense.
Yeah,
And
yeah,
only
yeah.
when you find binding, use it for your actual Icsi work. Do not straight
Absolutely.
away, put
Exactly.
the sample
Because
through.
again, see what matters is binding.
Yes.
If you do PICSI and all sperms are bound, then
It's a
you're
waste.
not making any difference.
Yes.
Okay. So basically, we are coming down that we have to improve our semen analysis beyond what we do, then identify categories where specific categories work. So anyway, that's not the topic. Now, people are asking very simple questions. If you are having a completely immotile sperms, what do you recommend? Expose the ejaculate or the sperms to theophylline or tessa?
Theophylline.
Yeah, do
You
or
don't want to do
non-invasive
anything
first.
invasive first.
Yeah. First,
Non-invasive.
first, best thing is to do some staining, viability staining, to see if
Yes.
there are viable sperm. And if there are viable sperm, then you can even try doing all this, Haas test, or if you have laser, you try, if you can pick up a sperm based on laser, and try pentoxifylline or theophylline. Why would you want to do
Yes,
testicular?
exactly. It's true. So Achyut Wadkar has an additional question to that, that in TESA samples where the sperms are immotile, but they do not have a laser, and if the HOS test does not show adequate or clearly visible tail kerning, then how can the viability of that sperm be accurately assessed?
Theophylline.
Okay.
And if nothing is working, worst case scenario, then you can, I mean, if you have nothing else and if you can't even freeze the eggs, then you can go ahead and test the soft tail hypothesis.
The flexibility
Yes.
of
So
the
if the
tail.
tail is soft to touch, then you can, we have done that on many occasions where there is no other resort. Those sperms have been injected and they work.
Okay, now there's a question. Maximum exposure time of sperm in PVP during ICSI? Maximum?
You have to minimize. There's no maximum time. Be as quick as possible because it will cause DNA fragmentation. It's at
Okay.
37 degrees.
And I
So
think the timing, and Sujata, this nice paper of concentration of PVP, 5%, 7%, and the outcomes. So I think that adds on. When more than 15 oocytes are there, how can we plan ICSI? How much time should we finish ICSI?
okay, so I'll tell you. I'll tell you the thing in our lab.
Now we are going to have a
You know,
debate, so let's make it.
so we
No
give a
debate
very.
now.
I tell them very balanced thing to do because I've got multiple branches and I can't see everybody every time. So when they come to training, and sometimes people tell these things that I'll take more eggs, I'll take more sperms, I want to do faster ICSI. Then and off late I found this little way of convincing the younger crowd because sometimes they don't want to listen. So I tell them, okay, the first thing I want is the time is 7 minutes. You take you will not take beyond 6 eggs. Now you want to take 2 eggs, 4 eggs, 6 eggs. Do you want to first go pick sperm, then get your eggs out? You figure out what works. At the end, I'll look at the KPIs, but I'm very particular about the timing and do not cross 7 minutes. So
That- Thank
then
God.
people,
Thank God you're saying this, Krishna. Then what was all the debate about before this, where I was only saying that time is very important,
time and temperature, pH, these three things are important,
right?
but
Time is most
it's about
important.
a balanced approach. We do not want people to just say that, oh, you know what, Krishna or Gaurav or Dr. Sujata, I've heard them saying we'll take multiple sperms or do this. They do not want to hear the whole thing. And watch out, what's important is, doesn't matter how many times we all have also spoken to senior faculty at times, but what most of us have done is we come, we do things, we log it, we write down, today I've done this, I followed it up. When things have worked, I keep doing it, and that is how it is added to our experience. What I see a lot of the youngsters not wanting to do is, end of the day, sit down and recapitulate. Self introspection is very, very important when you're in the learning phase. If you do not do this, you can never reach where your senior has reached. It's not about putting just the sperm into the egg and going off. It is multifactorial. We can't break and say, okay, 7 minutes will give you success, or taking two sperms or two eggs at once will give you the success. It is a coordinated effort of multiple things, and when you balance it, you win the game.
So I am glad that Krishna brought out some figures here, because today in the morning, when one of our fellows was presenting, embryology fellows was presenting study that she was doing using bicarbonate buffer, they actually clock the number of seconds that a dish is exposed outside the incubator during Icsi. And this doesn't start when the dish is placed on the micromanipulator. It starts when the incubator door is opened and the dish is taken out and placed on the stereozoom microscope. Because from there, the eggs have to be picked up, dish has to be changed, they have to be put in the buffer. Then the dish will be taken, put under the micromanipulator. So all the time gets added up. So the average time of exposure that she reported, the median time was 405 seconds that the dish was outside. And this is when you finish injection of the eggs, then the dish is taken back, eggs are picked up, put back into the culture dish and put back into the incubator. So which is 7 minutes.
Yeah.
And we don't want to expose the eggs for more than 7 minutes. So, and like you said, in 7 minutes, whether you inject 2 eggs or 4 eggs or 6 eggs or 8 eggs, it depends on the proficiency of the operator. And there are many people who are performing Icsi, right? So one person cannot be doing all the Icsis. So there's a person who is 20 plus years. He also might be doing, someone with 10 years is doing, someone with 4 years is doing, someone with 2 years is doing. But we know that what is the benchmark, right? So you always have to develop your skills towards a benchmark. Obviously, a beginner will do one by one,
Yeah.
right? But we know that what are the limits.
So here I would just like to, because I meet a lot of students all the time, the thing is people see the benchmark, but they do not see the process to which you have reached where you have reached. So they imitate the final thing. And I think one has to recollect that whole journey. The processes that have been taken, don't go, the benchmark is what you're aiming for, don't imitate it. I think that's
But
very
it has to be done under supervision again. So,
exactly.
there has to be a structure, there has to be a senior embryologist.
So when
Then,
you're asking this question in isolation, don't take it at just the words, understand the
yeah,
thing
yeah,
behind.
true.
Now, this is a related question, you've already covered it. How long can the ICSI dish can be outside the incubator without a closed system? Okay,
Yeah,
6 weeks.
about 10 minutes.
Yeah.
And do you advise a bicarbonate buffer without a closed system?
No, 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 no. Forget about bicarbonate. That's very new. Please stick to mops and hippies.
No, if you're giving it 10 minutes without bicarbonate, or even 7 minutes, what you have clocked, there is going to be a massive pH change.
No, we will soon publish our latest findings with regards to this, but this is something which is very new, so should not be tried like that.
No, even without principally, there is enough data that even if you get the dish out for a minute or 2 minutes, the pH rises subsequently and takes a long time to come back. So if you're going to be out for 7 minutes, the pH is going to go so much higher that you may be, you'll have more damage because of the pH and not anything to do with.
Yeah, but there are now, there are conditions where you can use certain kind of oils
Yeah.
and certain configurations of drop and overlay where this can be managed, but this is beyond the scope of this
One
But
has
for
discussion.
to
general
get the
practice,
data
please
for
take
that.
mops, heat
Yeah,
with
yeah. In
oil,
general practice, that's what I'm saying.
7 minutes.
Don't
We
advise it.
always use mops or hippies buffer
Correct.
where we know that they can handle the pH for a long time.
Yes.
And you make sure that you have adequate oil insulation and try to finish within 10 minutes.
Yeah. And then it's as many sperms or as many eggs, as long as you do it. Okay,
Yeah.
so finally, I think we'll just take the last question. We have overshot our time. So what morphological features do you prioritize most during sperm selection in ICSI? Head shape, vacuoles, or motility? I think Sujata has already covered this, but if somebody would like to summarize it, Sonal or...
So as was rightly pointed out, the motility would be the first thing that we will be looking into it, followed by the head morphology, and followed by the mid-piece morphology, basically.
Okay. So it maybe...
Head with no vacuoles
Yeah.
or less. I mean.
Yeah, small
Whatever.
vacuoles or no vacuoles. Yeah.
Okay. So now last words from all of you before we wind up, if there is any message. Yeah.
Since today was all about sperm selection, so please underline the word selection. And I think we all are got fancy with gadgets. I am also a culprit. Do not think I have not fallen for gadgets. But the embryologist's eye, his experience, the amount of stress you give to your spine is still what works. There isn't any evidence which has said that this is the magical technology, AI, microfluidics, or anything. I'm not saying you shouldn't be using it, but it is only in specific situations when indicated. It's an add-on. It might or might not help. There is no 1 + 1 is equal to 2 for sure. So I think until something really changes, we go by the book, by the rules. Do not, so your microculture conditions, your timing, temperature, pH, do not uh, overlook the bylaws of the lab. Respect them, and I'm sure success will always be in a controlled way with you. You overlook them, you go fast, you break rules. In that week, you will see, do this, and you'll see by Saturday your KPIs will come down. So I think I keep telling my team, it's a donkey's job. You just have to balancedly take the load and keep going. That's when it's going to work. Beat 1978, 1991 when people started, or 2026 when we're all doing this. I think this principle will not change. Do
Okay.
not just get too many fancy things in a fast way. Just because a webinar told you microfluidics might give you the best, or PICSI might give you the best, tomorrow morning just don't do all your cases with that. You got to
I
do it
agree.
when...
I agree that fancy gadgets don't help. I rather liked what Dr. Sujata said, that see the sperm and keep seeing and keep looking 10 times, 100 times, 1,000 times, 1 lakh times, and your eyes will know. And it's the experience of looking hard and with your brain processing everything together that which sperm seems better. So it comes with experience. And second thing is, uh, you will only know your performance when you note down the KPIs. So anything that you are doing, like for example, I just told you that we are also recording the time in seconds. So anything that you think is worth analyzing later, that whether you did well or not, if you don't have the KPIs, you will never be able to judge it will always be a impression-based, assessment. But if you want to really judge your potential as a ICSI practitioner, it has to come through data. So if you are standing on one leg and doing ICSI, you note that I stood on one leg and did the ICSI, that precise, and then you will know how you're doing.
Okay.
The embryology is actually changing a lot. We have been practicing from the 90s and we see this difference. Earlier, we all started, we had the advantage, to kind of fine tune our the number of donor oocytes and then we are also noticing, like we are responsible for every single egg we are injecting. Keep that responsibility and accountability in mind. Like this is not a race. ICSI is not a race. Like you don't have to win it with such clocking a short time. But like whatever we are doing is going to get us a healthy baby. Keep that in your mind.
Sonal?
Yeah, I would say just because you're doing ICSI for multiple years or you've been doing it day in and day out, I suppose that you should not overlook the fact that every egg is important. And you should be looking at giving a lot of respect to both egg and sperm while you're doing the job, no matter how many times you've been doing it.
So I think the message is loud and clear. First is, yes, like most youngsters want to start ICSI. They're quite disappointed when they're not allowed to do it. They are in a rush. I think before that, go for sperm selection. So spend a lot of time looking at sperms. The technique will come that you can do it. But first select the sperms, because even if you do a good ICSI and you don't select the right sperms, your outcomes will not be good and you'll be more disheartened. So learn first to select. There you don't need equipment. You can sit on your microscopes and do it. So I think we have really had a very long 2 hours, a lot of discussion, and I hope we've shed light. And over to you, Dr. Parsuram, for the final words.
Thank you so much. At the outset, now putting forward the vote of thanks for the event. This particular session today it's a very close to my heart, because I think almost throughout all the initial part of my career, I was always talking about sperm selection, IMSI, or microfluidic. So it was truly nice. And something that I always tell about or talk about sperm selection is like it is probably like a marriage without a divorce. Once you're done, you're done. And I don't know how many of you, as embryologists, would have realized that when you actually taken time and selected a good sperm and taken the pipette and all ready to go back and inject, suddenly you see a better sperm swimming next to your pipette. So just like how you get married to somebody and then you end up seeing somebody better the next day of so jokes apart, but all what we can do and all we can realize and do is what we can the best what we can do. I think the basic techniques still follow take the priority. Basic sperm selection, looking at basic morphology, and if you in selective cases where you feel there is an additional requirement is where you should start using these techniques. Please don't try to use all these newer techniques for all your patients. So thank you all once again. Thank you, Yamini. Thank you, Dr. Sujata. Thank you, Gaurav, Krishna, Sonal and Dr. Rajvi for the amazing panel discussion and a lot of discussion. Thank you all so much, and see you again for the next meeting of ACE. Thank you.
So for those, there were some people inquiring, it's all on the ACE YouTube channel. So if you have missed it or you want to go through any of the discussions, it's all on the ACE YouTube channel. So thank you. Good night.
Thank you. Good night.
Thank